And what struck me was that 40 years before, I had told an audience that half of all pregnancies were unintended. And that seemed to me to be enough of a reason to look again at how we were doing pregnancy prevention, how we were doing reproductive health services. And in large part, that's what one key question came out of. We came out of this frustration that in spite of many family planning clinics, Planned Parenthood clinics across the country, we were still in the same box. Next slide, please. Thank you. So yes, we were in the same box, except back in the day, you know, when I was doing this 48 years ago now, the unintended pregnancy rate really was fairly well distributed across income and race. And this is what's changed, unfortunately. Now we can really look at this and say, it's the women who have the least resources, right? Because as you look at the column in the middle there, which is greater than 200% of poverty, you'll see that only 20% are reporting an unintended pregnancy. And then when you go to the federal poverty line, you're looking at 112%, 58%. It's very loaded in terms of risk among the women who have the least resources. This is not about the women. This is about access. This is about the fact that around only 14% of women receive reproductive health services, contraception, preconception care in their primary care setting, and only 30% go to a specialty provider. So it's definitely about access to information and services. Next slide, please. And there's an even more dramatic differential when we look at infant mortality rates. Infants born to Black women have almost a 3 times more chance of dying in their first year than babies born to white women. That's huge. And this as a particular risk, again, is not just built in. It is not predetermined because there's some kind of predisposition among African American women to have a certain problem. But it is, once again, it's about access and services, which would include following chronic conditions in the health of the woman at the time she conceives. Next slide, please. And one thing I really like to point out, particularly to our primary care providers and those working in primary care, that there are screens that we do, it's required. You know, we do this routinely. We're checking for cancers and we're checking for hypertension and diabetes, alcohol dependence. We do not ask about pregnancy. And when you look at the lifetime risk of unintended pregnancy, it far outweighs the lifetime risk of these other conditions. And if you were really looking at only reproductive age women, even though we are routinely screening for hypertension and diabetes, those numbers are like single digits. So again, it's a reason to seriously consider the necessity of monitoring women's health before she becomes pregnant and giving her the opportunity to tell us what she wants relative to pregnancy. That is the critical piece, is the focus on what does she want. Next slide, please. The other piece that clearly plays into all of this is just lack of knowledge. I have to admit that I was surprised. With all of the information that is out on the internet, I just assumed everybody would know everything about all of the methods. And in reality, that's not the case. We still rely on what our friends are doing and what we read in the magazines, or online, I shouldn't say in the magazines anymore, but what we read online. And the bottom line of that is that women, while they may have heard about all of these methods, they really know precious little about really how they work and what they are, implants, IUDs in particular. So we're talking about, again, we're talking about this seemingly intractable problem of unintended pregnancies, and we are urging you all to consider going through a different door than the one you have been going through, or the one I was going through only, which was around pregnancy prevention. This is a different approach. And Becky is going to talk to you about what that actually looks like.
Thanks, Michelle. Next slide, please. So how does one key question fit in? It was designed as a clinical algorithm to improve screening and provide care based on what the patient's desires or wants were around pregnancy. Instead of having to be a yes/no response option, which often questions are, it does provide opportunities to explore ambivalence or neutrality about it. So the response options are yes, no, unsure, okay, either way. And it's really about taking every opportunity to, at every appointment with every patient, to ask to be able to promote the best health outcomes possible, whether that's for a healthy pregnancy, to prevent a pregnancy, or somewhere in between. And it equally supports those who want to get pregnant, who don't want to, and those who are ambivalent about it, that we can provide services and supports to you regardless of your answer and based on your answer. Next slide, please. The goal is really not to get someone to a yes or no. We often get that question in training, that even if they answer unsure, okay, either way, are we really trying to get them to a yes or no? And the answer is no. We want to take what they're saying at face value and provide the supports and services they need. It can happen in a variety of different settings: primary care, family planning, home visiting programs, WIC. It does not just have to be within a clinical site. Next slide, please. So really simple, what happens with each of the response categories after you ask, would you like to become pregnant in the next year? Your response options are yes, no, unsure, okay, either way. If somebody says yes, then you're going with the pre or interconception care, depending on whether they've had children or not. We highlight the importance of folic acid, the benefits of birth spacing. If you are a site that cannot provide the clinical services or screenings necessary, then you would need to have a referral site for your clients. Next slide, please. If your client says no, then contraception care is the direction. You can ask about their current use or prior use of birth control. Are they satisfied with that method? How is it working for them? And use a variety of guides and tools to help guide that conversation. That should be a conversation using like a shared decision-making model, for example, to both share information about contraception, but also hear from their patient about their expertise in their own lives. And again, refer to a medical provider if you're unable to provide contraception on site. Next slide, please. And then what do you do with the two categories in the middle? Unsure, okay, either way. This is when you would do a combination of both contraception and preconception care. We do know that about 20% of patients fall into this category. I forgot to mention, we usually hear about 70% say no, about 10% say yes, and about 20% say unsure, okay, either way. For, again, providing information about both contraception and preconception care, because there is a high likelihood of having a pregnancy when you're feeling ambivalent. Research shows that. So making sure that people have the right information about how to have a healthy pregnancy is really key here. Next slide, please. So how do you get started with implementing one key question? I think number one is to really recruit champions at all levels at your clinic, at your program, and your public health department, whatever your setting is. So both getting buy-in from the leadership and people who are making decisions, as well as frontline staff, those that are working directly with patients or with clients who see them day to day. You really need to get buy-in at all levels. And you can do that somewhat through providing information about statistics, some of the information that we provided earlier, also just showing how it can improve patient satisfaction or quality of care given in your settings. Then another step would be to participate in one key question certification training, which is a day-long training with follow-up technical assistance and support. We'll hear a little bit more, I think, later on about people's experience with the training that we provided for the first cohort. Then you'll want to start even before the training potentially, but during the training and then after the training, think about how you can integrate it into your workflow. What protocols or policies do you need to adjust or provide so that there's consistency across your system or across your program or team in implementing one key question? We always suggest piloting it with either a certain number of clients. So for example, with the next 100 patients that come in or next 100 clients, or for a certain length of time, like over a 3-month period, for example. Whatever makes the most sense for your setting is the way to make that decision. Of course, integrating it into electronic health record, that can often be a barrier, but it also is a big facilitator of implementing one key question. And obviously, you would want to be able to set it up to be able to track and monitor data based on goals that you have for implementing one key question, and then make adjustments as necessary. Next slide. We often get questions about, is it evidence-based or have you done randomized control trials? And while there hasn't been a large randomized control trial done on one key question as of yet, we are doing a small pilot randomization in Chicago, which we hope to have results later this year from. But in pilot studies, we have seen a lot of data around both provider and patient acceptability of the question, that it doesn't interrupt workflow. It's easy to integrate into a setting, into a visit. And patients really like the question. They like the 4 options for answers. In terms of outcomes and some of the pilot studies, we did see mostly around increasing contraception counseling, prescriptions, and changing of methods. It's a bit harder to track, or people have had a harder time track preconception care, counseling, and services. And so that's something we're helping to work with sites. And then of course we assess evaluation results as well from the trainings that we do. Next slide. So one key question really is focusing on understanding our clients' desires for pregnancy or around pregnancy, and providing the follow-up care based on what their response is in a non-judgmental way that supports people no matter what their response is. It can be very flexible, it can work in a variety of settings, and it's had success in a variety of settings. Next slide. In terms of what we are able to offer folks right now, we do offer the 1-day in-person certification training that we worked with cohort 1 on, and technical assistance around that. We have just developed a training of trainers, which would allow systems or programs to have internal sustainability and capability to train new staff or new programs as they come on board. We also have larger packages that does kind of an array of both training and TOTs, and also looking at integration with electronic health records, communications, evaluations, so a much larger package that can help integrate across a large system. And then we can provide follow-up and supplemental training on contraception, on contraceptive counseling in particular, because of our expertise in that area through our bedsider program, and then can connect people to preconception care support and services. Next slide. And lastly, we are working, everyone who goes through the training has access to our One Key Question Provider portal, and we are right now upgrading that to be something where you can view case studies, role plays, talk to each other to learn more about how people are implementing across the country. And we are developing an e-learning or distance learning opportunities to take the in-person training to an online platform. Next slide. And lastly, this is just a snapshot of about 30 different states that are using One Key Question in different forms. Some are doing it statewide, like Alaska and Hawaii. Others are doing it in certain counties or through certain clinics. But we are able to connect people to different states and different types of clinics or programs if they're interested. Next slide. And last but not least, this is our contact information. If you have any questions, and I know we'll both be on the webinar to answer any questions at the end. So thank you.
And this is Michelle again. Becky, that we had a couple of comments in the chat section while you were talking, so I'm just going to at least quickly address them. One is I do want to point out that this was an initiative originally developed in Oregon, and our process there was to get the endorsement of every primary care association, public health in the state. We also, however, got the endorsement of the American Public Health Association and ACOG. ACOG committee opinion is recommending that One Key Question is one of the ways to get at this issue, and particularly they recommend pregnancy intention screening at every opportunity. The second question, which had to do with breastfeeding moms, let me just say we have a great deal of respect for breastfeeding moms and protecting their capacity. So at the same time, we do not consider breastfeeding as a means of delaying as an effective means of delaying pregnancy. So we do talk about that in the training. In terms of a specific contraceptive training, that is something that's actually in addition to the one-day training we do on One Key Question, and it can be done as a webinar where there is need. And yes, that definitely would address the methods appropriate for breastfeeding. Thank you.
Okay, thank you, Becky and Michelle, for that very informative presentation. We're now going to move to Janet Jones and June Hankey, who are the co-chairs for TCHMB's Community Health Subcommittee. They will be sharing more about TCHMB and the One Key Question Quality Improvement Initiative. Janet and June.
Alrighty, I'm on. So could we have the next slide, please? Okay, I'd just like to thank all of you for taking the time out of your busy days to join us to learn about our initiative. I'm not sure how many of you are aware of the Texas Collaborative for Healthy Mothers and Babies. It is Texas's perinatal quality collaborative, and it is a multidisciplinary network made up of healthcare professionals throughout the state. And our mission is to advance the healthcare quality and patient safety for all Texas moms and babies through the collaboration of health and community stakeholders. Next slide. These are the goals of our collaborative. We want to reduce preterm birth and infant mortality, reduce the disparities in health outcomes of mothers and babies, reduce maternal mortality and severe maternal morbidity, improve the health outcomes of mothers and babies, increase the involvement of fathers and families, and improve women's health throughout the life cycle. Next slide. To accomplish these initiatives, we, through the collaboration of health and community stakeholders in the development of joint quality improvement initiatives, the advancement of data-driven best practices, and the promotion of education and training, we believe in communication, transparency, inclusiveness, and evidence-based work. Next slide, please. Now, at the top of this slide is the window of opportunity timeline in women's health. And this highlights the different time periods that we have to impact on women's health. We have 4 committees in our collaborative who are working on various aspects on this timeline. We have our obstetrical group that is working on that delivery time frame. It is, darn, I forgot to turn my phone off. It is that really short period, but what the obstetric group worked on was reducing failed induction of labor. And now that initiative is winding down, and they've moved on to maternal early warning systems. And that is in conjunction with the Texas AIM project that is working with most of the hospitals in Texas that do OB care. Now, the new natal group is one of our other groups, and they worked on increasing breastfeeding and human milk in the neonatal units. That quality improvement initiative is also winding down, and they are in the process of looking at a new project. Our project is the increasing access to reproductive health care and services through one key question protocol. And you can see that this initiative actually touches on every single point in this timeline in women's health. It's in that preconception, there's having the discussions in the prenatal care period. It actually impacts on delivery as well, because if the delivering hospital has the opportunity to provide the mom with an immediate postpartum ARC, then that can meet her needs for contraception if that's her desire. And then proceeding on to the other, the post and interconception period. We do have one other committee that is just in the process of being formed and developed, and this is our data subcommittee, because as you see, these are our quality initiatives to improve health in Texas. And we will be getting a lot of data about all of these different items. So the data committee, like I said, is getting formed, and they will also be looking for chairs for this committee. Next slide. And so, as we said, this is our project, increasing access to reproductive health care and services through one key question protocol. We initially had 4 clinics participating in our first cohort. We had one clinic who had to drop out due to personnel changes within their clinic. So now I'm going to turn this over to Janet, and she is going to provide us more specific information on our community health project.
Jones. I work at the Waco-McLennan County Public Health District here in Waco, Texas, and serve as the lead public health education specialist over the health education department. And most importantly, for the purposes of this webinar, I'm co-chair of the community health subcommittee. And our project is the One Key Question project. And if you can go back to that last slide, just to kind of highlight. Yes, so you see there at the top, preconception, prenatal, postpartum, and then post-interconception. This timeline is really important for just understanding why One Key Question was selected as the project to work on. In many communities, working on prenatal care or even postpartum only isn't enough in terms of working backwards to try to think about mitigating these poor birth outcomes and things that we're seeing within different populations. And so our project is very much so about increasing access to reproductive health care, whether it's in the months before pregnancy, handling a referral for someone who might find that they're pregnant when they go to the doctor, just really getting the providers to ask those additional questions regarding pregnancy intention. Next slide. So unintended pregnancy is, of course, something we see as a public health issue. You see the statistic there from Centers for Disease Control and Prevention, CDC, that almost half, 45% of pregnancies in the U.S. were unintended in 2016. That was from that perspective from the CDC, but in 2017, Texas ranked the 44th in teen birth rate. And then again, in 2017, the statistic around that 30.9% of women 18 to 49 in Texas who are at risk of unintended pregnancy. And so what these statistics highlight is just the need for priming women to have that conversation with their provider. And for so many women, and I can speak from what we see locally, that may not be something necessarily that they bring up on their own in a doctor's visit. Very much so, it's the doctor kind of being the one in charge of that conversation with the patient. So as much as we can provide that opportunity to kind of open that door for a woman to be able to provide that response and get her thinking about a plan that maybe she didn't know she needed to be thinking about regarding pregnancy, is where we can probably move the needle. Next slide. So our QI initiative is an approach that's intended to increase access to reproductive health care and overall reduce unintended pregnancies among women in childbearing age here in Texas. So again, unintended pregnancies. It's this protocol and this intervention is not at all about stopping those women who want to have babies. Instead, it's about asking that question so that if a woman does want to have a baby, she can then have conversations regarding preconception care and thinking about healthy eating and folic acid intake and all of those things that she does need to be priming her body for if she does intend to get pregnant. But for those women who don't want to get pregnant, it of course is helping them to have that conversation with their provider around contraception. The initiative will work with partner clinics to incorporate OKQ into their practice. So we're looking at clinics throughout Texas and wanting to get them involved in signing up to receive OKQ training with ongoing technical assistance from TCHMB, and will also participate in an OKQ learning collaborative and QI activities. Next slide. So expectations regarding participation in the project. If you're a clinic around Texas or you know of a clinic that does primary care, that you would want to say, hey, this clinic needs to be involved in this OKQ initiative, here are the expectations from that clinic and from that staff. So completing a clinic readiness assessment checklist, which is in the form of a survey, just to think through how ready is that clinic to actually begin implementing OKQ. Developing an OKQ plan, which would include timeline, it would include what part of the practice would be implementing, all of those different details, identifying staff to be trained, identify a representative to participate on monthly learning collaborative calls, which those have been going on with the first cohort since August of 2018. And so we meet monthly with the group for the different clinics to be able to kind of troubleshoot and think through any problems that maybe one clinic is having that another clinic could potentially support and help them think through. So you'd have to identify a representative for that. Review and complete the data use agreement, implement OKQ into practice, implementing quality improvement action steps, which you again get that technical assistance and guidance from TCHMB staff regarding how to do that effectively. Submitting OKQ measures to TCHMB. We do have certain metrics that we are wanting to collect regarding the intervention to think through effectiveness of the protocol, and then actively participating on other monthly calls and meetings. So the TCHMB Community Health supports and resources that I mentioned, technical assistance for the implementation of OKQ and QI in general, just that with the quality improvement framework and just how to do that implementation well. TCHMB would be giving TA for that. Facilitated learning collaborative calls, the support and structure for a quality improvement framework, providing funds for training of up to 3 staff, providing reports that show clinics, their process, and outcome measures over time, and compared to other de-identified clinics. So we don't put the clinic's names on there, but it will allow each clinic to see how they're comparing in regards to the other clinics that are in the cohort. Power to Decide provider OKQ certification after 2 years, and then access to Power to Decide OKQ provider portal. So this last slide kind of talks through a potential timeline for our second cohort. As I mentioned, we are currently in our first cohort, and so we are seeking clinics to enroll for cohort 2 of the TCHMB QI project around increasing reproductive health care and services. And so here you see kind of a mock timeline. There could be things that would shift or change, but everything is kind of flexible, but mostly in a range of when we expect for these things to take place. And so from April to June of 2019, you want to complete the enrollment packet of any new clinics who are wanting to enroll in the QI project. By September of 2019, the training on OKQ would take place. September to August of 2020, that would be the start of Learning Collaborative with monthly meetings and technical assistance happening for those clinics. Also September through December, we'd be collecting baseline data for those clinics who have signed up to be in the second cohort. For January through August of next year, we would want to initiate data collection and sharing with other clinics. And then February through July, during that time period, the quality improvement action steps. Again, TCHMB would be giving that TA regarding those steps. And if you would like any additional information, you see the contact number there for Nagla at 512-852-3198. And she is the person currently that you would reach out to if you know of a clinic or if you yourself are a clinic that is wanting to be involved in cohort 2 for this particular project. And I think now I will turn it over to Dr. Kelly Reynolds from the Family Health Center, which is one of our current sites in cohort 1, so that she can share about their successes and any challenges that they had in implementing OKQ here in Waco, Texas.
All right, thank you, Janet. So yes, I'm Dr. Kelly Reynolds, family medicine physician here in Waco, Texas. Next slide. Thank you. We opened our doors in 1970 as a family medicine residency program, and then in 1998 became a federally qualified health center. And we have 13 clinics in Waco, 1 in Temple. Most of our physicians are family medicine physicians. We have a few OB-GYNs and internal medicine and pediatricians. In 2018, we cared for 60,000 patients, providing medical, dental, behavioral health services. We take Medicare, Medicaid, and we have a discount program as FQHC. We have a discount program for uninsured patients, and we have some private pay and self-pay. And at various sites throughout our system, we provide all the contraceptive services, including LARCs, and then we do tubals at the local hospital. We are on the EPIC EHR. Next slide, please. As far as, what affected our decision to participate in the One Key Question, we have been a member of the local maternal child health coalition in McLennan County for several years. And we have been concerned about the poor birth outcome measures in our county, particularly among Black women. We've made a lot of effort to increase access and quality of our prenatal care, but we have not made much progress on the birth outcomes. And so we thought that addressing the preconception and interconception phase of life with One Key Question might help us make more of an impact. And I will say that the training that we received on One Key Question was also valuable in encouraging us to proceed. Next slide. So as far as our process, last summer we decided to start the program, and we decided to start our implementation with women age 18 to 50 during their annual or woman exam. And so we worked on building the question into our EHR, into the navigator section for the CNA or nurse who checks the vitals in and rooms the patient. Worked on exclusion criteria so that women who've had a tubal or hysterectomy are not asked the question. In January, we educated clinicians and nurses on the goals of the project and the workflow. And then in February, we actually implemented it, turned it on, so that the CNA or nurse is prompted to ask the one key question. She enters the patient's responses into the EHR, and that information is then presented to the clinician in the office note, as long as they're using the designated well-woman exam template. The clinician then is prompted to address the patient's responses and provide appropriate counseling and treatment. And then the next step, or the next phase, for a family health center, we plan to add the one key question to the rooming navigator for all women age, probably down to 17 to 50 annually or once a year, not dependent on the reason for visit. So if they come in for a sick visit, we would, if they've not been asked in the last year, we would go ahead and ask them. At some point, we may extend it out to all women every visit, but we have not made the decision to proceed to that yet. Next slide. As far as our experience, again, we started in February. So far, we've had 224 women who have had a well-woman exam using the designated template, and of those, 75% were screened with the one key question, and 60% had the appropriate follow-up or treatment documented in the EHR so that we could capture that information. So based on these results so far, we need more training for our staff and clinicians in order to improve the consistency of using the screening question and then addressing it and appropriately documenting. The main barriers has been time for the team to design, get it built in the EHR, train the staff, and then implementation. The time, of course, is in a busy clinic, taking time to review the questions and give the appropriate treatment, which is incredibly important, and then reporting. And then the facilitators, mainly the training that we had for one key question was excellent. And I will say that the monthly meetings with the TCHMB has been essential to making progress, because we have so many things going on. If we didn't have those monthly meetings to keep us on track, I don't think we would have made as much progress. And our staff is open to new projects and new workflows as long as we believe that it will help our patients, and I do believe this is beneficial for our patients. Thank you.
Thank you, Kelly. And now from JPS Health Network, we are going to have Misty Graham and Anjali Desai, who will share about their experience.
Provider group for the Department of Obstetrics and Gynecology here at John Peter Smith Hospital in Fort Worth. We are the county hospital here. We go ahead and move to the next slide. We've been working on one key question for quite a while. We were actually pretty far ahead by the time that we went to training last August. We started this as a collaboration with the Tarrant County Health Department. They actually reached out to the Department of Obstetrics and Gynecology to initiate this, to get some buy-in from us. And the biggest factor behind that was, much like our previous presentation said, the infant mortality rate helped us to kind of sell this along the way. Tarrant County has had one of the highest infant mortality rates in the state of Texas since the 90s. And it seems like, much like the previous organization, the health department had recognized they had done several initiatives that to increase access to care, that didn't really end with the result that we wanted. And so this was a means to improve from a different angle, to try to reach those women and try to make some improvements in the infant mortality rate. I will say that we've started ours in 2017. I think I'm missing a slide. I think I went past the first slide. Can you go back one? No, this is the first thing to talk about. Oh, we're missing the decision to participate. Sorry, guys. I have an old copy of the presentation. So go ahead and move to the slide that says process for implementing one key question. I think it was before that. There you go. I had them mixed up on my computer. So we met in spring of 2017 with the health department. In 2018, in August of 2017, we were able to push our early version of our EPIC template so that we could start doing this on all of our postpartum patients. JPS is a very large organization, and so the best way to start this was to keep it within the OBGYN department. And so the only way that we could do that was to trial it on our postpartum visits, since we were the only ones who were seeing those patients. It ended up being part of our poster presentation at our annual quality fair and was very well received. And then our next step had always been to move it to community medicine, where it was more of a primary care part of preventative health. And much like other large organizations, we have gone through probably two major regime changes here in the past couple of years, and that always delays progress when you need buy-in from administration to get things to move along. So we started discussing this with our community health, that's our outpatient primary care leadership, in early 2018, and meetings kept kind of falling through, and then we went to the training in June, and we weren't able to really get a good meeting after new administrators kind of got in place and got real grounded until February of this year. And so we met with them in February of this year, and it went very, very well. It was very well received. And then last month we started modifying our templates as we're getting ready to move them out, and to help measure some of the new metrics that have come out of this collaborative. Our next steps are to finish the EPIC changes, which we actually just did in the past week or two. And then in the next month, we'll be beginning a pilot for the one key question on our well-woven exams within the OB department and within one of our primary care sites. We have 3 primary care medical homes that have personnel from the OBGYN department embedded in those sites as the sole women's health provider. And so we made the decision to pilot at those sites so that the primary care providers could have a resource from our department who was already well-versed in using the one key question. Our big goal is that by the end of this year, that it's throughout all primary care sites, which are numerous, much like the other organization for well-woman exams. The ultimate goal for us is that it's an annual screening. And we could even argue that this could be done every visit, because pregnancy intention changes. It's not the same every 12 months. 3 months from now could be very different than what it is today. Go ahead and move on to the next slide. So between August of 2017 and February of this year, we had asked this question 2,510 times to 2,265 unique patients at their postpartum visits. On a note, I will tell you JPS averages 4,000 to 5,000 deliveries a year. And so 2,500 sounds great, but to us, that's still a 50% return rate for postpartum patients. When we asked postpartum, as you would think, the majority of the answers that we got to one key question were no, I am not planning to I do not want to get pregnant within the next 12 months. Surprisingly, there were some yeses, there were some okay either ways, and some unsures. And I think even within our OB department, where this is what we do on a regular basis, we're comfortable having these conversations with women. This helps to bring some of those things to the forefront, because I think it can be very natural to assume that women don't intend to get pregnant within the next 12 months, even within the women's health field. But it's quite eye-opening to see that some of them are actually intending to do that. Of those who said that they did not want to become pregnant within the next year, 34% were already using birth control. And we've done some big work here at JPS to make sure that those women leave the hospital with their birth control, whether that's a prescription or inpatient LARC administration. Go ahead and move to the next slide. So barriers. Biggest barriers are changes in administration that are out of our control, that delay some of the movement on our timeline. Perception of lack of time in primary care. When we met with primary care leadership, we already anticipated those were going to be the concerns, and so we had some great responses for them. But for those who do work in primary care regularly, in family medicine particularly, within our organization, we have a ton of programs that we're measuring and tracking metrics for that require already substantial time for inputting patient information. So even though this is a very small question, the fear is that it leads to larger and longer conversations that they can't accommodate in those visit times. And then the other barriers is the majority of our primary care providers are not as comfortable as those in the OB department of having those conversations with patients about pregnancy intention, and then where to go if they, based on what they say, whether they're not well versed in preconception counseling or even various forms of birth control counseling. So the way to get this done here at JPS, we've decided is we've got to have our leadership buy-in, and we had to improve our templates. So we took some advice and some thoughts from the primary care providers because their workflow, even within our same EPIC program, is very different than ours. So we didn't want to assume that we knew the right way or that this wouldn't impact their flow. So we brought it to the table with them, framed as, this is what we want. How do you see that working for you? We also worked hard to improve our referral process. That took work not only on the provider side to ensure that we had enough staff in the clinics who had available appointments for patients to get in to be seen, but it also took a lot of work from clinic administration to improve the staffing that we currently had and the process that we had for ordering referrals and managing the referrals and assessing schedules to ensure that they are utilized fully each day. We do have providers. We have 3 large health centers for women, and then we have our medical homes, but where's that slide? I'm sorry. I'm looking for, I was trying to tell them, I think we skipped that one. No, how many clinics overall for primary care? There it is. Yeah, mine are flip-flopped. So while our clinics are only 7 in totality for the outpatient side, there are 117 community health clinics out there, 15 locations that perform adult well visits. Community health completed over 600,000 encounters last year, serving over 140,000 unique patients. About 3,600 well women performed annually in the community health primary care setting. At the Health Centers for Women, this is all we do every day, our obstetrical and gynecological care. The stats say that we average 97 women seen per day for 25,000 unique women served a year. We have the primary population of our indigent and underserved women, average age of 35, large percentage of Hispanic Latina patients, and then evenly split probably between our African American and our Caucasian patients. Go ahead and move to the next slide. Thank you. Our community health clinics, primary care provides women's health services, geriatric services. We have a homeless clinic here at JPS, cancer care, pain management, sports medicine. We have just about everything here, including an HIV clinic. And quite interestingly, when we first bought on as the OB department for this, the health department had already reached out to our HIV clinic, Healing Wings, and they had started to pilot this on a very, very small scale for their patients. And it created openings for major conversations that had not been had before, particularly for women who were HIV positive, had never been asked, do you intend on getting pregnant? And that stoked conversations of, well, I didn't think I could. Well, can I? And it was quite life-changing for that clinic and for the patients at that clinic. So we have now good buy-in support from our leadership. I feel like our leadership is stable, in a stable place compared to where we were about a year and a half ago. And so I think that this is going to move on. I think we're going to be very successful. I would recommend that if anyone else in the organization is put in that place where you have to have those discussions with administration, administrators a lot of times speak money. Please remind them that improving pregnancy rates, the intention for pregnancy, the availability of contraception, the preconception care does translate into big dollars. If you can prevent those pregnancies that are high risk, those babies that have sequela after preterm birth, or any other things that go along with poor pregnancy planning. The cost of healthcare for high-risk pregnancies and your sick pregnancies and your sick moms and babies is very, very large to those organizations. And that speaks, well, I found in my personal experience that is where we really got the most buy-in from our upper administrators, is when you talk about how this translates into dollars for the community and the overall success rate and health of the community as a whole. Go ahead and move. Is there one more slide? That's the last one. Yeah. So this is where I thought we started from. So when we met with primary care, at first it seemed a little skeptical because it sounds like one more thing that's going to be on our plate that we have to do. We talked about how one key question is aimed at prevention, right? We're preventing unintended pregnancies. We're preventing poor outcomes by opening those conversations to get patients in the right place for preconception care. So this needs to fall under preventative health. And I think that when we brought it to them that way, they were very much on board. When we walked through how one key question works, that it's very short, doesn't take a lot of time, but you get a wealth of information out of it, and that we've reassured them that we have set things in place so that while they may not be as comfortable to provide the counseling to those patients, they do have a place to send them and where they can get in quickly. They wouldn't be waiting in a referral queue for months and months and months. And so I think that making this easy on their part also helped to get buy-in from our primary care groups. I'm trying to think. Is there anything that you wanted to add on, Julie? Okay. So I think that's really all for us. It's been well received so far, and I think that I'm excited to see where this goes in the future, especially if we can get to the point that this is a regular screening for all women who step foot in JPS, that primary care looks at those screenings before making decisions for medication or treatment, and that we can see that this has made a big improvement in our pregnancy birth rates, maternal mortality rates, and infant mortality rates in the coming years. I don't have anything else.
Okay, thank you, Ms. D'Angeli, for that. And thank you to all of our participants today. That does conclude the presentation portion of our webinar. We will begin to respond to the questions that you've been submitting throughout, and please continue to submit questions as they come to you. We will be sure to answer all of them. But real quick, before we begin answering questions, I did want to let you all know about TCHMB's next annual summit. It will be next year here in Austin on February 27th through 28th. And this is an extremely informative conference that you won't want to miss, so please be sure to save that date on your calendars. With that, we will start with the first question. Let me pull it up. Those questions have been answered already.
Yeah, but not every.
All of the questions and answers you can see in the chat box. We'll go through. Some have already been answered out loud. Some have just been answered on the chat box. Just a moment. Here's a question: how and where would you get one key question training? Then the ACOG's committee opinion on pre-pregnancy counseling, and in the chat box there is a link to that. And Becky said that the training is available through Power to Decide, and if you join TCHMB's Quality Improvement Initiative, you can. We will work with Power to Decide to provide that training. Another question about, is that training at a cost to the individual, or is it covered by the grant? And the answer to that is that it is covered under the grant for 3 representatives from the clinic. There will be more detailed information shared for anyone who is interested, and you can contact tchmb@utsystem.edu. Or NELERIAN@utsystem.edu. Again, both of those email addresses are in the chat box if you are interested in getting more information. A question that just came through that has not been answered yet is there a need for funding to implement this project? Do any of our participants want to answer that?
I would say, this is Dr. Reynolds, I would say the main cost was our IT time and that it took to build this into our EHR. And then some time for training. So there's always a cost with the time for that.
Thank you, Dr. Reynolds. Does anyone else have anything to add to that? Okay, another question we have is, have people successfully used one key question in the context of home visits or with community health workers? That one hasn't been answered yet. Do any of our participants want to answer that one?
Hi, yes, this is Becky from Power to Decide. We have done a lot of work with home visitors and community health workers to implement. So it has been successfully implemented. For example, Hawaii is doing it statewide in their home visitation programs. We've been doing work in other states recently in the context of home visits. So yes, it is possible and feasible to implement. What most home visitors need to set up though is make sure they have the right referrals for the clinical care if they're unable to provide the clinical services, which most of them are not in the context of home visits. So making sure they have those warm referrals for people to seek the clinical care is really important.
Okay, thank you. That's the last question that we've received so far. If I missed your question, please resend it, or if something else has occurred to you, we will wait another couple of minutes before we end the webinar in case there are any last minute questions. We are always available for any questions if something else occurs to you after today. Again, tchmb@utsystem.edu is the best email address to use for future questions. And the recording from today's webinar, as well as the slides, will also be available following today's presentation. So the slides from today we will send out to everyone who registered for the webinar, and then they will also be posted on our website, tchmb.org. I don't see any more questions coming through right now. So with that, we'll go ahead and end our webinar. Again, thank you to all of our presenters today for participating, and for all of our attendees for joining us today. We really appreciate your attendance today. Thank you.